Good morning all, and thank you for joining today's session on the last day of Value in Health Week. My name is Amanda Willicott, one of the Programme Managers for the Value in Health team, and I'll be joined today by my colleague Dr. Rob Palmer. After a brief introduction, the intention of today's session is to provide some thoughts and considerations of where you should start when aiming to analyse a PROMs dataset for maybe the very first time. So I actually started my PROMs journey about 7 years ago while working in the orthopaedic department at Cardiff and Vale University Health Board. We started looking at a department-wide standardised approach to collecting PROMs, mainly to monitor effectiveness of treatment. However, while embedding PROMs collection into the usual care pathways, we realised that the data could help enhance the patient consultation and could be used to monitor patients without the need to bring everyone back to a face-to-face appointment. It was this work that led me to the role in the Value in Health team. There will be more information about the data collected at Cardiff in the presentation at 1 o'clock today. Next slide, please. We've heard this week that the value in healthcare is realised when we achieve the best possible health outcomes for our population with the resources that we have. Our value in health approach focuses on meeting the needs, goals and preferences of patients by involving patients more in decision making. Being able to support this decision making with the best evidence possible is therefore crucial. So how do we do this? Outcomes can be seen as the important milestones in the lives of patients that matter to the patients themselves. Therefore, we need to measure this, to assess and meet patient needs, to understand patients' experience of care and to improve services. Therefore, a key element of the value in health approach is to electronically collect patient-reported outcome measures, PROMs, routinely at pace and scale, embedding the collection and the utilisation of PROMs as business as usual. Next slide, please. So what are PROMs? PROMs are standardised and validated questionnaires completed by the patient, which forms a structured assessment to measure patient perception of health and functional well-being. These can be completed before and after treatment or over time to determine if there's been a change in the patient's condition and health-related quality of life. The questions are designed and tested with patients and clinicians for either specific conditions or for general health and health-related quality of life, and are often used together to gain a broader picture of that patient's health status. Next slide, please. So, condition-specific PROMs ask questions specific to a given condition or disease. They focus on a specific area of health, so are very detailed, and they are sensitive to monitor change. It's this level of detail that makes them useful to clinicians in order to understand their patient problems and therefore become useful for personalising care. On the other hand, general quality of life PROMs measure overall well-being and can be used to compare between different conditions, for example, between knee arthritis and heart failure, as well as within one condition area. They can be used in clinical and cost-effectiveness analysis and therefore are useful to compare costs and outcomes for different treatment. But we see that general quality of life PROMs are not so sensitive to disease-specific changes. Next slide, please. The value in health strategy places the utility of PROMs at the heart of its vision. So creating a system which is data-driven, that uses outcome data to provide timely information and to inform decision-making is crucial. There are key data products which are being developed to support this vision. So firstly, Indirect Care. An important use of PROMs is a tool to support direct care, and data visuals are being created in the patient's electronic clinical record to facilitate this. Using PROMs in direct care can assist in a number of ways. For example, providing a defined structure to a consultation and can act as a symptom tracker or needs assessment. It allows patients to consider what matters to them most before the consultation and to consider issues they may not have previously identified as relevant. It also helps facilitate the discussion of difficult and sensitive issues and that two-way exchange of knowledge and decision-making. Overall, PROMs can assist with more flexible ways to deliver individual care, especially within the current environment. Therefore, PROMs could be collected prior to be used to enhance a video consultation. They could be used to support remote monitoring following treatment, to assess if there is a deviation from the expected outcome. And in addition, it allows patients flexible access to record outcomes and therefore allows for patient-initiated reviews and to be seen on symptoms or when a condition flares up. Secondly, PROMs can be used for quality and improvement. Aggregated patient-reported clinical outcome and case mix data is also being brought to life in data dashboards. We have seen the heart failure and the lung cancer dashboards this week and the knee arthroplasty dashboard at 1 o'clock today. So aggregated analysis can assist with identifying low-value practices and then assist with relocating resources to high-value interventions, identifying areas of good practice and reducing unwarranted variation, and assessing population needs and understanding whether those needs are met. It's the bespoke analysis that can then assist with answering any questions posed from the data. So there are many ways that PROMs data can be used. And with all this in mind, if colleagues within health boards are starting to use this data for the first time, it is essential that consideration is given to how the data collected will initially be analysed. Next slide, please. I will now pass you over to my colleague, Dr. Rob Palmer, who will introduce himself and further discuss this PROMs analysis.
Thanks, Amanda. Yeah, I'm Rob. I work for CEDA, which is a healthcare technology research centre in Cardiff and Vale Health Board, and I'm part of the analytical team for the Value in Health programme. So what I'll try to do with this bit of the presentation is to point out some things to consider or think about if you've been given a PROMs data set or intend to start analysing some PROMs data and you're not sure where to start. So I realise that there's a lot of different ways you can collect PROMs, so I've tried to keep this generic, but I think most of what I'll talk about applies in some way to analysing most types of PROMs data. So have the next slide, please. So following on from Amanda's introduction, I'll be quickly showing some examples of different types of PROM scoring, as well as things to consider when starting a piece of cohort analysis. So what I mean by cohort analysis is that you're not looking at the PROM in isolation or a single patient in isolation, but looking at many PROMs at the same time, perhaps to find trends in patient groups or to compare patient groups or to find trends over time, such as looking at average scores and so on. So firstly, PROM scores are overall scores that are used to give an overview of the answers to multiple questions in a PROM tool. So in other words, a scoring algorithm takes the answers of multiple questions by a patient and converts them into a single score, which can make analysing the multiple domains of a PROM tool much easier and gives us an overall picture of how the patient is doing. So most PROM tools will have some sort of scoring algorithm to do this, but there isn't a one rule fits all when it comes to scoring a PROM, and each scoring algorithm per PROM tool may be different. So in some cases, the guys who've developed and owned the PROM will have created a piece of software, maybe an Excel macro or a website, where you can upload patient responses and it'll return the score for you. But it's far more common for them to just provide a scoring manual, which is basically a document with instructions on how to convert responses into an overall score. So I've got three examples I'd like to show you, which will hopefully give an idea of the different types of scoring that are out there. So have the next slide, please. So the first example I have is the EQ5D5L, which is a common generic health PROM. So it has 5 questions, which you can see on the left there, and there are 5 answer options per question. So to score this, the PROM owners provide instructions on a lookup table. And in this example on the left, the patient has responded with the first answer option for questions 1, 2 and 3. They've answered with the second option for question 4 and the fourth option for question 5. So following the instructions, this creates an answer profile of 11124. And a lookup table tells us that the overall score for this patient in the UK is 0.537, So this is quite a straightforward example of PROM scoring. So can I have the next slide, please? This next example is the Oxford HIP score, which is a HIP-specific PROM with 12 questions, and they've all got 5 answer options. And you can see an example of one of those questions on the slide there. So a scoring manual is provided, which says that this time the overall score is reached by simply summing the scores received for individual questions. It also has guidelines on how to deal with missing answers. So if only 1 or 2 questions have been left unanswered, we should enter the mean value of their responses to fill the gap. But it also says that if more than 2 questions are left unanswered, they recommend that an overall score should not be calculated. So some scoring manuals will tell you how to deal with missing data, but some won't. And sometimes this kind of info can be hidden away somewhere like obscure in the document. So it's always worth a thorough look through the document before starting to score our PROMs. Let's go to the next slide, please. So this last example I'm going to show is the QLQ-C30, which is a generic cancer PROM and has 30 questions, and you can see 5 of those questions there on the left. So this one is a bit different to the previous 2 we've seen because they've used all the questions in the PROM to come up with a single score at the end, whereas this C30 PROM, so there's no overall score for this one, but instead there are sub-scores which represent overall scores of part of some of the questions in the PROM. So in this document, they actually use the term scale for a score. So for example, the QL2 scale at the top of the table only uses the responses to questions 29 and 30, but the PF2 scale just below it only uses questions 1 to 5. So also for this PROM, depending on which of the scores or scales we're calculating, we may have to use a different scoring equation. So if we were calculating any of the scores under the functional scales heading, which is the orange heading in the table, we need to use the second equation below the table. But if we were calculating any of the symptom scales or the global health status, which are under the yellow headings in the table, then we need to use the third equation below the table. So the scoring manual also provides information on how to deal with missing answers in this case. And so in this case, this was found on a completely different page to the rest of the scoring instructions. So again, it's worth a thorough read. So I guess what I wanted to show from these examples is that there are many different types of scoring algorithms out there with different levels of instructions and detail. So if you have a PROM tool and you know there's a score or scores associated with it, but you don't have the scoring manual or the software, then in most cases they're made publicly available. But if not, get in touch with the PROM owner who should be able to point you in the right direction. So can I have the next slide, please? So now I'll move on to talk about things to consider when putting together a data set ready for cohort analysis. And there are a few things that affect this, and these are: what question are we trying to answer? What additional info from the PROMs, apart from the PROMs, do we need to be able to answer this question? And finally, how does your collection system or collection process actually collect PROMs from patients? Let's have the next slide, please. So the types of questions we might ask could be: is there a difference in the average score between the first PROM and the last PROM that patients completed? Or we could ask: is there a difference between the scores at referral for patients with different BMI? Or is there a difference in the average gain in PROM score after surgery between patients of different ages? Or maybe we could ask: is there a difference in the average PROM scores after 2 months before surgery and 6 and 12 months post-surgery? Now, of these 4 questions, as you'd imagine, the first one is probably the least useful one. And it's the least useful because it doesn't look at the PROMs with respect to any clinical events on the patient's pathway. So for example, patient A might have completed their first PROM before surgery, but patient B might have completed their first PROM after surgery. And so there's a risk of not comparing like with like when trying to answer this question. So the other questions that I've got, they refer to clinical events such as referral and before and after surgery, which brings us on to what additional info do we need. So can I have the next slide, please? So to answer these questions, other additional info we may need could be patient demographics, or probably more importantly, pathway event dates, such as the date of referral or the date of surgery for the pathway that the PROM refers to. To get that info, we probably need to link to other hospital admin or clinical data sets, unless we're really lucky and someone else has already done that for us, or we have systems in place to ensure that everything is linked during the actual PROM collection. So this bit can be a bit fiddly and complex, and how complete our hospital data is plays a big part in how fiddly this bit may be. So as we don't have long today, I'm just going to quickly point out the kind of thing that's worth considering when linking to hospital data. So as I said, if we have a pathway ID, then we're very lucky as everything should be taken care of. But if not, we might want to consider hospital and patient IDs to make sure that we're linking the right PROM to the right patient. We might want to consider clinical codes and anatomical area to make sure that our referral or surgery date is for the correct condition. So many patients are on multiple pathways at the same time. So for example, if we have an Oxford hip score PROM, we want to make sure that we link that to a referral for hip arthroplasty rather than a referral for cataracts, for example. We'll also want to consider the anatomical side, as in the side of the body. So for example, patients may have surgery on their left hip as well as their right. So we'll want to avoid linking a referral for treatment on a patient's left hip to a PROM where the patient was filling it in about their right hip. And finally, we may want to consider whether the referral or surgery was for a primary procedure or a revision, and which of these did the patient consider when completing their PROM. Let's go to the next slide, please. So lastly, and personally I think this is very important and easy to miss, it's worth considering how our collection system or collection process actually collects PROMs from patients. So we may have a data set that looks like this, where we have one row per patient and a series of columns with responses, scores and dates of a PROM at one time point, for example pre-surgery, a series of columns with PROMs info at another time point, for example 6 months post-surgery, as well as additional info to help us answer the question, such as the data I just mentioned on the last slide. So if our data isn't in this format, we probably want to rearrange it into this format to make analysing our data a lot easier. But before going ahead with analysis, I'd like to encourage everyone to check that the dates that we have in our dataset actually make sense clinically. So I've seen many people, including myself, being caught out by this by just assuming that a neat and tidy data set like this is pretty much ready to go, but often it isn't. And I've got a few examples of different collection systems on the next few slides to try and explain why. But just to set the scene, for the next few slides, we're going to try to answer the last question on the last slide, which is there a difference in the average PROM scores up to 2 months before surgery and 6 and 12 months post-surgery? So the next slide, please. So the first example I have is what I'm going to call a rigid collection system, where only one PROM submission is allowed per invite, and the PROM must be submitted within a specific deadline, otherwise that invite closes. So an example of this might be when patients are asked to complete a PROM on paper or on an electronic device during a scheduled clinic appointment. So the circles in this diagram represent a clinic appointment, or in other words, when a patient is asked to complete a PROM. So the red circles may represent a pre-surgery appointment, which can happen at varying times before the surgery itself. And the green circles may represent a follow-up appointment 6 months after surgery, and the blue circles may represent a follow-up appointment 12 months after surgery. Let's go to the next slide, please. Now in this system, patients will complete their PROMs on the same day as being asked, which is what the X's represent. So our PROMs here are nicely lined up and pretty much ready for analysis. But to tidy things up even more, we should refer back to the question of, is there a difference in the average PROM scores up to 2 months before surgery and 6 and 12 months post-surgery? Let's go to the next slide, please. So using a time boundary before the date of surgery, we can see that one PROM was completed more than 2 months before surgery. And so in this case, we need to remove that PROM for analysis to be able to answer our question. Other than that, the PROMs are nicely lined up, and we can take the average of the red PROMs versus the average of the green PROMs versus the average of the blue PROMs to try and answer our question. So the next slide, please. So the next example I have is of a rigid-ish system. I wasn't quite sure what to call it. But in this case, only one PROM submission is allowed per invite, but the PROM can be submitted at any time after receiving that invite. So examples of this are when patients are sent a paper copy of a PROM through the post and they send it back when they complete it, or when patients are emailed a link to a PROM, and once submitted, the patient can't complete another until another invite has been sent out. So data set may look like what's in this diagram this time. So where the PROMs are returned at any point after the invite was sent out. So you can see the X's are not bang on at the same time as where the invites were. So you can see that in this example, the patient 3's pre-surgery PROM was actually returned after they had surgery. And patient 2's 6-month PROM was returned just before the 12-month PROM invite was sent out, which is the green X next to the blue circle there. So I realise that these examples may look extreme, and although I'm using these just to illustrate my point, this kind of thing is actually what we see in real data sets. And I found an example on the next slide. Scroll to the next slide, please. So this is an example of a very neat and tidy PROMs data set that we've received, with one row per patient and columns for the pre-surgery, 6-month and 12-month PROMs. But I'd like to point out the patient highlighted in orange. So apologies if that's a bit small on your screens. But so they completed their pre-surgery PROM in February 2016 and had their surgery in May 2016. And I know I haven't included the surgery date in this slide because it's off the screen, so apologies for that. So they've completed their pre-surgery PROMs in February 2016. They had their surgery in May 2016. And then they completed their 6-month PROM in November 2016, which is pretty much bang on 6 months after the surgery date. But if we look in the 12-month PROM date column, which is the blue column, they've completed their 12-month PROM in September 2017, which isn't 12 months after surgery, it's actually 16 months after surgery. So this PROM has been put in the 12-month post-surgery PROM column because that's when it should have been completed, but the patient actually completed it 16 months post-surgery. So we should ask, is it right that we include this PROM in our analysis? You know, is there a difference in the health of patients at 12 months compared to 16 months? If there is, including this PROM in our analysis is going to skew our analysis results. Let's go to the next slide, please. So the last example I have is of a pretty flexible collection system where there's no limit on the number of PROMs that can be submitted per invite. And once again, the PROMs can be submitted at any time after receiving that invite. So an example of this might be when patients are sent a link to an electronic PROM and they submit it when completed. Once submitted, the patient is allowed and can resubmit additional PROMs at any time using the same link invite. So this time our data may look like this. And we can see the patient 4 has completed 2 pre-surgery PROMs, one before surgery and one after. And patient 3 has actually completed 3 6-month PROMs. So once again, these PROMs are not nicely aligned, and we need to do more work before we can crack on with answering our question. So go to the next slide, please. So there may be other ways to address this, and I guess it makes no difference how we clean our data as long as we're transparent about what we've done. But one solution could be to forget about when the PROMs were actually sent out and only concentrate on when the PROMs were submitted. So we're allowed to do this as the PROM sent out at pre-surgery is the same as the PROM sent out at 6 months, which is the same as the PROM sent out at 12 months. So the questions are exactly the same. This is always the same PROM tool we're asking the patient to complete. Let's go to the next slide, please. So by considering our PROMs in this way, we can identify the PROMs we should use to analyse by using the same method as we previously used to rule out inappropriate pre-surgery PROMs, which is to use the time boundaries. So we could choose a boundary either side of the time points we want to analyse. So in our case, we want to analyse up to 2 months before surgery, and then at 6 months and 12 months post-surgery. So by picking the amount of time we're happy for a PROM to deviate away from that time point, in this example I've chosen 2 months, we can set boundaries either side of our time points. So 2 months before and 2 months after, for example. So any PROM that falls outside the boundaries can be discarded. And if a patient has more than one PROM within the boundary, such as patient 1, who has 2 PROMs that are falling within the 12-month window, which is the blue window, then we could use the nearest one to the time point we want to analyse. Go to the next slide, please. So going back to what we originally had, I'd like you to keep an eye on patient 2's 6-month PROM, which is the green X next to the 12-month invite. And then if we go to the next slide, please. So now we're actually using that 6 months PROM as our 12-month PROM for analysis, as it makes more sense for that to be used as a 12-month PROM. So after using our time boundaries, our PROMs are now nicely lined up, and taking the average of the red PROMs, which is the average of the green PROMs, which is the average of the blue PROMs, might give us the answer to our question. I'd also like to point out that in this example, we've collected 19 PROMs from 4 patients, but we might only use 8 of these for analysis in this case. Also, although all 4 patients replied to every invite they received, only 1 patient has replied in a way that they are valid PROMs at all 3 time points. So if we only wanted to consider patients with PROMs at all 3 time points to answer a question, which is probably the most correct thing to do, we go from having 19 PROMs from 4 patients to using just 3 PROMs from 1 patient. And this brings me on to my next slide, which is not to be alarmed when cleaning our data that we end up not using a lot of the data we've collected for any single piece of analysis. Let's go to the next slide, please. So at every stage of the data cleaning process, or even during the analysis, we'd expect to lose a number of our PROMs in a data set. So this can be as a result of linking PROMs to other hospital data when there aren't enough completed data fields to complete linkage, for example. Or as we've seen, we can lose PROMs in patients by ensuring that our PROMs are lined up and make sense clinically. We can also lose PROMs during the actual analysis. So if we're only interested in analysing the overall scores, for example, then we may lose patients who've answered some questions, but not enough for the scoring algorithm to give them a score, as we've seen previously. Or alternatively, if we wanted to explore the effect of a factor such as BMI on PROM scores, then we may have all the PROMs necessary for the patient, but if we don't have their BMI, we obviously can't use their data. So it's very rare to be able to use all the PROMs we've collected for a single piece of analysis. And to be honest, I don't think I've ever seen an example of that, unless it's a strict clinical trial or something like that. So these are some of the reasons why we often see reports with analysis of very few numbers, even when they've actually collected quite a lot of PROMs. So can I have the next slide, please? So I'll move on now to things to consider after we've put our data set together and to start to actually do some analysis. So what I'm going to describe is sort of a standard approach to how to go about doing any sort of analysis, not just PROMs. So apologies if you're familiar with this already. So I guess what I'd like to put across from this is that there should be a difference in how we approach doing a bespoke piece of analysis with PROMs compared to a more automated dashboard-like analysis, which I'm sure many of you have seen examples of those throughout this Value in Health Week. So I'm also going to talk specifically about analysing PROM scores here rather than responses of individual questions. So let's revisit the question of, is there a difference in the average PROM scores up to 2 months before surgery and 6 and 12 months after surgery? Well, which average should we be looking at? Is there anything else we should be looking at, or are there any statistical tests that can more accurately help us to answer that question? So for example, maybe we should be calculating the mean and the standard deviation of the scores and performing parametric stats tests. Or maybe we should look at the median, interquartile range and non-parametric stats tests, or maybe there's something else we should be looking at. So without spending any time on this, using the means and the standard deviations may give us a more accurate understanding of our data, but calculating the means is not always the right thing to do. Calculating the medians is pretty much okay to use for most data sets, but they do give us a less accurate understanding of our data. So I'm not a statistician, so there are others who can better explain this to me. But how do we decide what we should be doing to answer our question? Let's Let's go to the next slide, please. So usually we do some sort of preliminary analysis on the data in order to help us decide what analysis we should do to answer our question. So there is a set of common stats rules which basically say if your data looks like this and you want to find that out, then you should do this. And as I said, I'm not a statistician, there's plenty of info out there to get an introduction on this sort of thing. So some of the things that affect how we should go about answering our questions are, do we have continuous data, interval data, or ordinal data? Do we have enough data to be able to tell us something meaningful? So if our numbers are too low, for reasons we've already discussed, maybe the results that we're seeing is just down to chance. Or is our data normally distributed, i.e. is our data skewed or not? So things that can skew our data include the nature of the PROM question itself and the wording of the question. So we've collected PROMs from unrepresentative group of patients, or again, low numbers can cause this. So for a bespoke piece of analysis, we can spend time doing the preliminary analysis, which will tell us what our data looks like. And based on what our data looks like, the stat rules will guide us as to the more correct way of trying to answer the question. Let's go to the next slide, please. So for dashboard or more automated analysis on our PROM scores, we're more likely to ask the dashboard to show us the average scores at pre-surgery, 6 months and 12 months post-surgery, rather than asking, is there a difference between these 3 time points? And the reason for that is that finding out if there's a difference or not is often not clear-cut, and we usually need some human interpretation on these results. But anyway, we end up with the same question, which is, should we show means and standard deviations, or medians and interquartile ranges? So to help us know which to choose, we can either automate the preliminary analysis that we would have done with a bespoke piece of analysis, or we can just choose right from the off what we're going to show. So trying to automate the preliminary analysis can be tricky, as again, it often needs human interpretation to decide which route to go down. So maybe choosing a safer route from the off might be more realistic. Let's go to the next slide, please. So I'll try and give a quick example. Say we start collecting PROMs in January, and we want to create a dashboard which will show us the average scores of our PROMs in real time. So we can log in at any time and see the average scores of the PROMs that we've collected. By February, we've collected 25 PROMs in total, and by September, we've collected 250 PROMs in total. So calculating the mean on the 25 PROMs is probably the wrong thing to do according to the stat rules, as the numbers are so low, but calculating the median is doable. Calculating the mean on the 250 PROMs might actually be doable this time, and is probably the preferred option, but calculating the median is also doable. So if we didn't want to rewrite or edit our dashboard code that shows our averages every time our data looks different, then we might want to always calculate the medians in this case, as it would be okay to do both in February and in September, whereas the means would only be okay to do in September. So I've given the example here about numbers, so higher numbers we're probably allowed to use means, lower numbers we're probably not, but the same goes for if the data is skewed or if the data is unrepresentative as well. So to summarize, when we're doing any bespoke analysis, we should always look at the data we have and what it looks like before deciding which method we use so we can apply the most appropriate one. But for dashboard and automated analysis, we want to be able to rely on a standardized automatic process that doesn't require any human input. So for this reason, we should always use safer options, such as the medians in this example, as they always give us a more correct output, whereas in some instances, using the means would give us incorrect and misleading results. Let's go to the next slide, please. So before moving on to decision making, I just wanted to very quickly cover a minor point on analysing the responses to individual PROMs questions. So I've been caught in this trap, and I know others have too, but basically in the vast majority of cases, the answer to PROMs questions are ordinal. So the example on the left there has the answers no, never, yes, some of the time, yes, most of the time, and yes, all of the time, which are numbered 0 to 3. But these numbers don't actually mean anything, they just put the answers in order of severity. So if we were analysing a bunch of responses to this question and we decided to calculate the mean, we may end up with a value of 1.7, say. Now, what does that value of 1.7 actually mean? All it tells us is that on average, patients responded with somewhere between yes some of the time and yes most of the time, which turns out not to be very useful. So it's much better to calculate the median in these cases, although some might argue otherwise, as you could still end up with the midpoints. So probably the safer option would be to calculate the mode, or to just show the distribution of the answer responses, as you can see in the bar on the bottom right. Let's go to the next slide, please. So finally, I'd like to discuss some things to consider when making decisions based on the analysis we've done. So ideally, we'd obviously like to do the perfect piece of PROMs analysis in order for us to make very confident decisions. But of course, in order for us to do that, we probably need the perfect PROMs data set too. So we know that it's pretty much impossible for us to just sit and wait for the perfect PROMs data set to be collected before we try and make some decisions with it. So there are some things we should consider when making decisions based on the data and analysis we already have. So one of these things might be that our analysis has ended up being on a low number of PROMs or patients. And I've discussed how that might happen earlier on in the presentation. So doing any sort of analysis on low numbers raises the risk that the data is actually unrepresentative, biased or skewed, or that any differences or similarities we see between groups of patients might just be down to chance. So if there's a risk that your analysis might be susceptible to any of these due to low numbers, that should be taken into consideration when we intend to make any serious decisions based on our analysis. Secondly, the maximum time between a PROM being completed and the time point we're trying to analyse might cause us to take our analysis with a little pinch of salt, maybe. So going back to our time boundaries on the top right of the slide, if we wanted to know the average score 12 months post-surgery, then how far away from that 12 months mark are we willing to set our time boundary? So choosing a very narrow boundary window would give us more accurate results, but we'll end up discarding a lot of PROMs. But choosing a wide boundary will allow us to include more PROMs in our analysis. But would this make sense clinically? So I guess this will be a judgment call and probably needs a discussion with the clinician. If our analysis is tending towards any of these extreme scenarios, then I guess that also should be considered when using our analysis results to make decisions. Similarly, this also applies to the minimum time between PROMs at different time points. So in other words, if we decide to use a wide time boundary window, then our green window on the top right might get very close to the blue window. It probably doesn't make sense clinically if we use a PROM from patient A, which is towards the right extreme end of that green window, as a 6-month PROM, while also using a PROM from patient B, which is towards the left extreme end of the blue window, as a 12-month PROM, if those two windows are really close together. Another factor we might want to consider before making decisions with our PROMs analysis is have we performed appropriate statistical tests to ensure that any differences or similarities we see isn't down to chance. So for example, we may have calculated the average score at 6 months and it appears lower than the average score at 12 months. But how do we know if that's not just down to chance or not? So the statistical test will give us a better idea on that. So on the same note, have we provided all of the relevant information to be able to confidently make a decision? So calculating the means or the medians on their own often aren't enough to give us an idea of what's going on and to be able to make confident decisions. We might also want to show standard deviations, variance, interquartile ranges, and so on. So finally, I'd like to quickly discuss comparing PROM scores between different cohorts of patients. So the box plot I have on the bottom left shows the distribution of PROM scores of patients who drink more than 14 units of alcohol on the top row, compared to those who drink less than 14 units. So on the face of it, without showing you the results of the stats tests, it looks as though those who drink more actually have better PROM scores. And similarly, on the bottom right, I have an example of a funnel plot which compares the average PROM scores of patients who were given different femoral brands during knee replacement surgery. So it looks as though brand number 4 produces worse PROM scores than all of the others. But what we should consider is, are there any other factors that might have contributed to this result? So for example, for the alcohol results, maybe those patients who drink more are also a lot older than those who don't, or maybe they have more comorbidities, for example. And for those patients who've been given a femoral brand number 4, they were in fact much older and had a higher BMI than those patients who were given other femoral brands. So is it the femoral brand that caused a low average PROM score, or was it because those patients tended to have a higher BMI? So to account for these confounding factors, there are statistical methods we can use to try and find the true cause, and we can case mix patients to be able to more evenly compare like with like. So I won't go into this now, but if we don't use these methods to try to address these confounding factors, then we should definitely consider this before making any important decisions. So that's all I've got this morning, so I hope that's been useful and it's pointed out some things to consider when starting a piece of analysis with PROMs data. So could you have the next slide, please, and I'll pass back to Amanda.
Thank you, Rob, for that very detailed assessment. We now have a little time for some questions, and I'm just looking to see what has come in prior to and during our presentation. Rob, I think this one's for you. So a question has come in around the advantages and disadvantages of collecting PROMs in different ways, whether it be that paper, electronic, in person, or by post, for purposes of data analysis. So what are the disadvantages and advantages of collecting PROMs in different ways?
Sorry, can you hear me now? Yeah. Yeah, so I'll refer back to the three examples I had in the slide. So I talked about a rigid collection system, a rigid-ish, and a flexible collection system. So with a rigid collection system, so the patient tends to complete the PROM on the same day or within a very tight deadline of when they were asked to complete it. So in those sort of cases, when it comes to doing cohort analysis, the advantages of that would be that the data is pretty much, it's almost ready to go. You haven't got to do a lot of work around it to align those PROMs up. But obviously you are limited to the number of PROMs you actually collect overall. So if you were looking at the data, you know, at a patient level, you've got less data points to play with really and to look at trends for that individual patient. Whereas for a flexible system, you know, you're collecting a lot more, you're potentially collecting a lot more data points, but to work with an aggregated or cohort analysis, the data is a bit messier, so you've got to do a little bit more work to be able to line those PROMs up. That's what I'll try to discuss in this presentation. But on a patient level, that's really good because you've got a lot more data points for the individual patient. So there are pros and cons to both.
Okay, thank you. We've had one or two comments here around sharing the presentation. Actually, I'll read the one out. This is fabulous. Can't scribble notes fast enough. Hope this can be shared later. So yes, all the recordings of the presentations will be made available later on the website. So we'll be keeping in touch with regards to that. So I'm just looking at time. I think we've got time for one or two more. So the next one, this is so helpful, thank you. How many PROMs are we expected to lose when cleaning data? Can you put a number on it?
Probably not. So the reason is, you know, there's lots of different reasons why we end up losing PROMs. So like one reason might be linking it to hospital data or clinical data, for example, and that just comes down to how complete your data is. So if your hospital data, all the fields are completed, you've got it all nicely, you know, filled in. Same with the PROMs data, then linking it shouldn't be too much of a problem. So you might, if your data is quite complete, you're probably less likely to lose a lot of PROMs. And similarly with the alignment process of your PROMs data, you know, with a rigid-ish collection system, you're less likely to lose PROMs because your PROMs are pretty much already lined up. But with a flexible system, you're more likely to lose PROMs because you've got to do that alignment process to align your PROMs up. But then you'll have more data points overall. So yeah, it's not really an easy question to answer. It just depends on how complete your data is.
Okay, thank you. there was something that came in around always see analysis for PROMs for more surgical conditions, and can we analyse PROMs for chronic diseases in the same way? So I know you did focus on more surgery, didn't you? But are we able to analyse PROMs for chronic diseases in the same way?
Yeah, so I mean, yeah, all the examples I showed there are for pretty much for surgery or acute conditions. But I guess with more chronic diseases or chronic conditions, sorry, to be able to do so for the patient level, it doesn't really make that much difference, because really, if you're looking at the patient's data in isolation, really what you want to know is, has that patient got better or have they gone worse? Whereas if you were doing an aggregated piece or cohort analysis, you still want to be able to line up your PROMs so that they're in nice columns. You take the average on the columns. So you still need to sort of tie the PROM to some sort of clinical event. So they might not be the clinical events might not be so clear cut for a chronic condition. They might not have a surgery, they might be on medication or something instead. But maybe you could do it could line up the PROMs from the time of referral or from the time of diagnosis, for example, rather than align it from time of surgery, as I've shown in these examples.
Okay, so we're just about out of time. I'm going to quickly make a few comments about one question that's come in around collecting PROMs for patients in the community receiving appliances. So yes, I'm sure PROMs could be collected there. It's really a case of looking of what PROMs would you might have something in mind, but what PROMs would suit that patient cohort. So why do you need to look at the data? What are you trying to get out of the data? Are you looking at experience, which we haven't touched on today, but is it PROMs? But more than happy to have another conversation about that at a later time. So we are out of time. We will try and get back to everybody regarding their questions at a later stage. Over the next couple of weeks, and we'll try our best to cover all that. So thank you for listening, and goodbye.